So grateful to be here at the RAC again. Day is absolutely amazing. She was teaching before she had to teach this morning in the hallway. She's always mentoring, always teaching. She is a true gatherer and general in healthcare, and we just salute you and Justin and your entire team for putting together a great faculty, organizing a great event. We're truly thrilled to be here again in the actual event. We want to thank our sponsors as well. They're great. They're awesome. If you're on LinkedIn, please follow me, Ed Norwood, as we have some fun fights with CMS, especially the unreasonable peer-to-peer timeframes by certain MA plans, and we'd love for you to be a part of that. Follow me at Ed Norwood on LinkedIn. Heard an interesting story of an old man who went to the doctor and said, Doc, my wife can barely hear. And the doctor wanted to suggest a test to see how severe the hearing loss was. And so he told the man, go home, stand far away, and ask her a question. And then slowly move up as you ask these questions to see when she first responds to what you've said. So the old man rushes home and finds his wife preparing supper and says, honey, what's for dinner? No response. Goes 15 feet away and says, honey, what's for dinner? No response. 10 feet away. Silence. Finally, he's 5 feet away, and he's saddened by this time, and he says, honey, for the last time, what's for dinner? And she said, for the fourth time, it's lasagna. What if? What if payors won't listen? We all have them. What if questions that identify a fear or a danger, an uncertainty, hopelessness that paralyzes the appeal or peer-to-peer review call? I've interviewed peer-to-peer reviewers who've shared with me that in certain scenarios, they could tell what the payer is going to say before they say it. And the fear of what they don't want to happen sometimes just gets in the way. We have these what-if scenarios that are swirling in our head. I was traveling here from Los Angeles, a 5-hour flight, and there's a guy in front of me. He is looking in the back of the plane 50 times. And at this point, I'm a little nervous. And I'm getting this what-if question in my mind. What if he's a hijacker? What if he's trying to get the plane? Okay, if he goes for the plane, I'm going to take his knees out, and then this guy is big enough to take his head out. And I just start playing these scenarios in my head of what to do if this guy goes for the plane. And so these questions that we have, these scenarios, what if? What if I'm not good enough? What if I don't have what it takes to overturn the denial and get the care the patient truly needs? What if I can't win? What if I lose? What if the patient dies? But the human voice is one of the most powerful instruments that we have. It inspires armies. It responds or it reacts. It heals or destroys. It builds or tears down. Yet it is often silenced by giant voices that say scary things like need medical records, scary things like not medically necessary, or denied per interqual or MCG. And in healthcare, often we have become hostage negotiators with those problem plans, those giants who hold our patients, our authorizations, and our dollars hostage and send those patient EOBs or letters saying, I need 1,000 unmarked medical records by 5 p.m. tomorrow. And then I'll release your authorization or money. But today is the day we say no to that giant. Today is the day we tell MA plans no and learn how to advocate for medically appropriate care pursuant to a case called Wickline versus State. We did that for a particular patient listed here. A couple of years ago, she was a stage 4 breast cancer patient given weeks to live. And her payer who denied her care as an experimental and investigational, wasn't listening. Within 3 days of citing the peer reviewer as having a malpractice award against him, we were able to overturn that denial for her. And she reported in this particular email, since being approved, she's received her first clear PET scan. She took a seasonal job at Nordstrom's, going 45 hours a week. She finished a credentialing program. She's planning a 25-year anniversary trip with her husband to Europe, and she is now in remission because of the work that you and I do every single day. Please write this down. No resolution, no rest. No resolution, no rest. No rest. No rest. She concluded this in her email that you're looking at. What this means to me and my family is that I don't think in terms of weeks or months anymore, but years. I'm ever so grateful for this gift of life that I've been given. Please write this. What you do with what you get determines life or death for your patients. How you fight, how you appeal, how you challenge issues. How did we do it? Well, we filed a complaint, and we used Anthem's policy against them in the complaint. We also cited that the doctor that had denied the care had a malpractice award against him. And I find it interesting that oftentimes in law, attorneys will look up the opposing counsel on the state bar, but in medicine, doctors don't do that. And so we've begun to start a movement where we're challenging physician advisors and case managers. When you are denied for medical necessity, go on the state medical board and see who denied your care. Oftentimes, those websites can provide you with information if they've been on probation, if they're disciplinary action. It can tell you if they are paper pushing, if they're involved in patient care, or simply administrative work on a daily basis. It could speak to them being, if they're competent, if they have the education, the training, the expertise to make that decision as required by 42 CFR 422.590 G2. You should write that down, by the way. It'll change your life. Couple of days later, 3 days later, here's a copy of the actual state board information that we provided for this particular doctor that showed the disciplinary action. 3 days later, Anthem overturned that no to a resounding yes. How do you respond, though, when payers don't listen? Let's talk about that and jump right into it. How do we prevent denials? Oftentimes, our front end is in the job of denial prevention, and our back end is in the job of denial management. And so we've begun to ask our case managers, how can we do a better job preventing denials? How can we take those tracking or reference numbers and convert them to authorizations before we bill, before we give the plan the ability to deny them? How can we ensure that we make sure that we're meeting certain timeframes as required by federal law in preventing certain denials? Have you created libraries of letters and laws, fax cover sheets, registration forms? Have you created policies and procedures? I love what Devon said, workflows. Have you mapped out workflows of how you're going to work each denial? Do you have a denial checklist for certain denials, such as a request for medical records, Or are you simply providing medical records every single time they ask you for it? We have something great in our office called a blurb library. That's where we refuse to recreate the wheel over and over and over again. So we have a no claim on file blurb. We have a non-emergent blurb. We have a post-stabilization denial blurb. We have a timely filing blurb. And we've just created this blurb library, so at any point, we can, instead of starting from a blank piece of paper or a blank screen, we can copy and paste over and apply our facts. We've created flowcharts and processes. We've gone into hospital systems and shadowed and interviewed doctors, ED staff, insurance verifiers to figure out how they do what they do daily and how we can recommend changes that improve the front end or prevent denials. How do we manage them? We've helped provider members create denial management lists, such as this one on your screen. Because we want to be able to show an aggregate number of denials by a particular plan at any given time to CMS to show them this particular payer has engaged in conduct that could impact beneficiary access to care. We have an issue in Arkansas, one of our provider states that we work in, and they're facing Payors, I don't want to call their name, Ambetter, who is stating that when the patient is incapacitated or intubated immediately or has an altered state of consciousness, we should hear from you within 24 hours. And so we've begun to work with the Arkansas Insurance Division to challenge that particular denial and gain success overturning it when in the medical chart there was proof or evidence that the patient could not provide their insurance information. And so we would create something like this that says MA, notice we use the acronym for the plan in front of the denial category, MA, unauthorized, and then create root causes. Why was it unauthorized? Patient came in incapacitated. Patient was a 5150, we could get nothing from them. And we've created denial codes that give us the ability to flag what plans are doing. If we see a huge trend of UHC using their buddies, EquiClaim and something core doing the downgrade DRGs, how do we make sure we can flag that and show an aggregate number of issues to CMS to stop the practice? And then, of course, how do we write the appeal? Here are a few things that we've taught for years in terms of writing the appeal, and I want to go over some things. I'd like you to write some of them down if you can as well. Number one, I want you to identify the denial reason. Believe it or not, plans are telling agencies when we file complaints, well, when the provider wrote the appeal, they never appealed that. So it's important that you identify the true denial reason. For instance, if a plan sent you an EOB and a letter that stated, need medical records, or denied for you not providing medical records, you cannot become reactive and give them medical records just because they're asking for them. You have to go back to Genesis, to the beginning. You have to figure out how the patient arrived there. If we as a hospital made contact and the plan failed to provide an authorization within 1 hour as required by law to determine if they're going to get the medical records in the first place. In fact, please write this down. We've had fun with this, and I'm very serious about what I'm going to give you right now. It's one of the statements we want to be able to give you. It's important that you have the ability to push back on plans when they're asking for unnecessary medical records, and you have proof that you made contact, you sent clinicals every single day, they issued a tracking number, and now they want to conduct a retrospective medical review. Please write this down. This will change your life. Your requests for medical records has been denied. And if you don't learn to begin to do things just like that, and we'll touch more in the other presentations, you will find yourself creating a precedent for the plans. Well, Ed, when do you give medical records? If they're trying to figure out, if we've proven that we have called you, you've given us an authorization, you gave us a tracking number, the patient's now gone. If for some reason they're asking for medical records to determine how to pay the claim, I'll provide those. And there are other scenarios where workflow might restrict me in fighting this hard, and I'll share some of that also in a later presentation. So we want to identify the denial reason really, really well. If you have that scenario for medical records, it's a post-stabilization type denial where notification was made, post-stab was not paid for. Don't call it a medical necessity denial. It's an ER, no pay, post-stabilization, not paid. Sometimes they pay the ER. It's an ER paid, post-stabilization, unpaid type of denial category. Then you want to make sure you determine the correct jurisdiction, of course. And we've created an interesting statement of facts. The statement of facts uses 3 words I want you to write down. We dispute because, as shown and described below. We dispute because, as shown and described below. Just repeat that with me. We dispute. Can't hear you. We dispute because, as shown and described below. Now, what we're trying to do with that statement of fact is, in case the plans do not read your 60-page thesis letter, that in that statement of fact by itself, we will tell them what the dispute is. It's a statement of fact. So here's some examples. We dispute Payors' name, denial of this claim as not medically necessary because Payor was notified on January 15th and failed to issue an authorization within 1 hour, deeming the services statutorily authorized as shown and described below. Just in that sentence, we've shared with them what our position is. There's one listed there for no claim on file as well, and we'll create one together at the end of this session also. Number 4, you want to attach exhibits to document the facts. Notice how our timeline begins with how the patient arrived. Patient arrived with severe crushing chest pains. Patient arrived with gunshot wounds to the chest. We're trying to make sure they know why the patient was here and trying to strike any sense of consciousness that exists within them. Then notice we will also provide exhibits of what took place. Anything you are arguing, you want to create great exhibits to show when you made contact. I had a HealthNet attorney some years ago. I formed a Meet the Healthcare Health Plan Payor forum, and she came and she said something in the very beginning that I was very upset with initially, but then respected later. She said, you know, Ed files all these complaints against us, and I understand why he has to do that, but here's what I'm saying. We can resolve more of your issues if, when you send the letter, you don't just say, this wasn't paid per contract. Because we get X number of thousands of denials every single day, and our people are not going to leave their seat to go and find your contract to see how they would have paid it. So if you provide us an exhibit of that contract and circle the pertinent section you believe we should adhere to, it makes it easier for us to overturn that particular issue. And so it's very important that you provide exhibits that support your position. Exhibits that show you did send the medical records. You did send the medical records. You did send the medical records. I have a fax confirmation. Here it is. You want to be able to demonstrate that you have followed the rules of the actual plan. Then, of course, locate administrative laws that support each argument, number 5, and then apply the law really well. You don't want to just copy and paste the law. Here's a great example of application. Here, payer was notified on January 15th, but failed to assume responsibility of the patient within 60 minutes prior to patient's discharge, ending their financial responsibility. And then, of course, you want to land the plane. You want to impose deadlines. Tell the payer what you want. Here's a great example of that. Please release the federal funds intended for the Medicare beneficiary on or before this date to prevent any unnecessary regulatory complaint action. Now, it's important. I cannot tell you how many letters I've seen that did not have a deadline. How important is a deadline? On April 15th, every single year at the 24-hour post office, there is a line around the corner because people are trying to meet a deadline. And so it's important that you create deadlines in your particular letter. So here are the three words I gave you before. We dispute, because, as shown and described below. We dispute, because, as shown and described below. And if you begin to train your staff how to create statements of fact using those words, I believe it can increase your overturn success rate. Here's just an example of a timeline, how we've created a timeline. In this particular exercise, we're dealing with careless senior plan, and you can see that patient presented to the emergency department with severe crushing chest pains on 11/1/15. On the same day, the hospital called careless, and representative stated that the patient was eligible, gave them effective dates and a tracking number. On 11/2, there was a face sheet that was also sent to them, notifying them that your patient is here. You could add, even after that, the days you provided clinical reviews. On 11/3, 11/4, X day, on this X date, we provided clinicals with no disapproval from your organization. And then, of course, you can see that we ended by stating when the patient was discharged. In your timelines, it's important to demonstrate with Medicare Advantage plans when the patient left, to show when the patient arrived, when you made initial contact, and when they left. There's an interesting law we'll go over tomorrow under 42 CFR 422.113 C3 that talks about the end of the MA plan's financial responsibility. And if they fail to pre-approve care or assume care of the patient or enter into an agreement with you for the patient to stay there, their financial responsibility for services they have not pre-approved ends upon patient discharge. Because oftentimes you'll find they will give you a tracking and a reference number and disappear. And they will not show up until it is time to bill them, and then have the audacity to ask you to bill with medical records. I had you write something down initially. It was the first thing we wrote down. What did it say? Your request for medical records has been denied. Please cease and desist from requesting improper medical records for services you were notified on or authorized and failed to assume care before the patient left. And so you'll find that we will do that often just to ensure we can fight medical necessity denials that are coming. And then, of course, to date, no payment has been released. Then you want to identify the denial, the jurisdiction. There's a line there where we can create a statement of fact that's really powerful in challenging the actual payer. And then, of course, we talked about timelines with exhibits just some time ago that are really, really pertinent. Then as you apply and build the law, you want to have the ability to use certain terms. Please be advised that 42 CFR 422.113 states, furthermore, this section of law adds. You want to have transitional phrases or words that lead you into each argument. And each argument, it's important that you have the ability to apply really well that argument. Notice here I gave you an example. Here, careless senior plan was notified on this date, failed to pre-approve care within 1 hour, or transfer the beneficiary while hospitalized, which means the financial responsibility ended upon patient discharge. And then you want to end the letter. It's important that you understand that when an MA plan fails to reimburse services that the patient would have under Medicare Part A and Part B. In fact, let's write that down. Under 42 CFR 422.101, it says the MA plan is financially responsible to arrange payment for anything that is covered by Part A and Part B. And that section, Part 4.2, is the exclusive section, as Dave mentioned, for Medicare Advantage plans to function out of. It's important that you share with them when they fail to reimburse you, they have failed to release federal funds, please write that, federal funds intended for the Medicare beneficiary. You must stress the importance of that. Policy challenges. What are some of those? Well, under 42 CFR 422.590B2, it speaks of non-contracted plans who have an obligation, if they uphold your denial, to forward that to an IRE or Maximus. And we have begun to see disturbing trends where plans are not forwarding certain cases to the IRE, or there is confusion as to which cases would go to the IRE and which would go to the CMS regional offices or 1-800-MEDICARE. On the last day, I'll talk to you about the process of filing complaints directly with CMS, which complaints go to CMS, and how to make sure you maintain your rights, your appeal rights under Part 422. In this scenario, United Healthcare was conducting a DRG validation. They were denying that care based on a DRG reduction, and you've seen these hostage letters, right? These ransom notes where they simply ask you to agree or disagree if the DRG they've chosen is accurate. And then you have a choice within 30 days to check that box and tell them you disagree. And hopefully you're providing a supplement with that of why you disagree. That's important. Here you'll see that the provider sent something back to them disagreeing with their DRG. Then Equiclaim at the very bottom there stated that we appreciate your response, but our original determination still stands. Then, of course, we took the case, filed a complaint with CMS. Here's the CMS complaint form that we will try to dissect on the third day, how to file that form with CMS. And we sent this to the actual plan, and we simply spoke initially of the fact that the plan did not forward this issue to the IRE. They were a non-contracted plan. There were some concerns that they had barred the rights of the Medicare beneficiary from being able to appear before an ALJ. We later found out that different denials go to the ALJ and some go directly to Medicare. Again, we'll go over that on day 3. To make a long story short, you'll see that UHC then sent an email back stating to one of my colleagues, Brian, in regards to CMS case number, and there's the C case number, Optum responded to me on 8/24/18, and attached you'll find a list of claims with their new appeal numbers. 2 of the claims appear to have been paid. So I want you to see this. They downgraded the DRG. And then upon us filing the complaint with CMS, they reopened the appeals and started paying them. I think to date, they got probably about maybe 20 cases from us, and they have, initially rather, and they have overturned about 9 of them without it going any further, just because we challenge the DRG with the findings of HIM or the findings of that person on the UR team and filed a complaint with the CMS regional office. We dispute because, as shown and described below. So how do we create a statement of fact when we have a plan that doesn't receive medical records? Here's one that I've created, and I encourage you, take a picture of it, write it down. But real simple, simply says this: we dispute your date denial of not receiving medical records because medical records were faxed or uploaded with a fax upload confirmation, and the plan may be in violation of HIPAA Privacy Rule 164.530, mishandling PHI as shown and described below. Now, when you ask great questions or you make great statements, you will hear awkward stretches of silence on the phone. And that's how you know you've got the payer's attention. In closing, we must advocate for medically appropriate health care pursuant to Wickline versus State. You must be a voice for those who cannot speak for themselves. You must be an advocate for those who are underrepresented. Write that word down, advocate. An advocate is simply one who defends the rights and causes of another. Because not only do your patients face a giant in the form of a diagnosis, they face giants every single day in the form of insurance payers unless you do something about it. Thank you.